So we are ready to start post-lunch session. We start first post-lunch session first with chairman orations. Our chairperson, past president API, Dr. Y.P. Munjal and Colonel Dr. G.B. Chaudhuri to come into dais to start the session.
Good afternoon, friends. It's our privilege and honor that a very learned person who is going to be the chairman Am I audible? Okay. He's going to be the chairman of the chapter. He is a person who is humble to the core and a very knowledgeable person. I think introducing him to the audience in this hall is telling the man who is known to all. Therefore, I would not say many more words except to say that he is professor of the National Medical College, a prestigious institute of Calcutta, and this is a physician's meet, therefore he is a physician first and a neurologist later, and that makes him an excellent clinician and a humble person. May I request him to deliver his oration.
Respected Chairperson, sir, thank you very much, sir. Dr. Y.P. Munjal, who is the pioneer in the field of API and ex-president, you all know. I also extend my thanks to Colonel Chaudhuri, my esteemed delegates, my friends, senior friends, and also my student friends who have come over here. So this is probably the last time I am going to deliver the oration as chairman. The previous oration was there in Shiliguri with Ijapicon, and this time with Gcdc. So as a treating physician, what are the emergent situations which can come in movement disorder is my topic of the day. So if we just consider that what are the emergencies in movement disorders? Some things it is surprising. Why there should be some emergencies? Movement disorders are usually considered as just like chronic disorders. And when we talk in terms of different types of movement disorders, we usually try to designate with a particular phenomenology, because whenever there is a particular abnormal movement, our first idea is to give a phenomenology, whether it is a hypokinetic movement disorder or it's a hyperkinetic movement disorder. The prototype of the hypokinetic is the Parkinson, and for the hyperkinetic, we get a number of disorders starting from your bellismus, chorea, athetosis, myoclonus, and so on and so forth. So first to divide like that, and then we go for finding out the etiologies in those situations. But what are the emergency situations sometimes which can be very detrimental on the part of the patient, and at the same time it's maybe a challenging problem for the part of the treating physician. And these are the videos, few videos I have taken, which are the real life video. One video I have borrowed from one WhatsApp, rest of the videos of my own. Some videos were given by my late mentor, Professor Shamal Das, and he actually gave me a few videos. Also he had gave some videos to Dr. Bhaskar Ghosh. We have kept it as a treasure. I will go on talking with this thing, and probably you will be benefited by my discussion as a treating physician. So what would be the spectrum which I like to tell? This is an acute onset movement disorder as an emergency, or emergency situation which can be due to disease related or disease unrelated. And movement disorder is a manifestation of first serious underlying disease. So today's menus will comprise emergency situation, acute Parkinson, encephalopathic, etc., and like this I will go on last to the psychogenic. So in a hospital, that is survey was there, the causes of emergency admission in Parkinson disease were a lot of causes like this. So what I can tell you as a treating physician, I was called to the orthopedic ward once upon a time, and I find that the patient had developed severe abnormal movement, completely rigid. He had a fractured neck. And actually he was a patient of Parkinson's disease, and Sindova was stopped all on a sudden. And after 2 days he was completely rigid, and a call book was given to me. So I went into the detailed history, because the falls are very common in Parkinson's disease, and that may cause an emergency situation. Besides these things, number of other disorders can produce emergency situation in Parkinsonian patients. Now, emergencies in Parkinson's disease may be manifested by the severe dyskinesias, in which we can get the increased leukocytosis, CK, blood urine nitrogen. Patient even can have present with a heart failure or shortness of breath. Sometimes during the treatment, we can get the psychosis in case of Parkinson's disease, which is due to the underlying medical disease. In that situation, you need to reduce the dose of the adjunct medication and try to go with the lowest possible dose of levodopa. Parkinsonian hyperpyrexia syndrome is always a known entity. So now I will show you this video. You see this lady. Actually, this lady she is completely rigid on presentation. She cannot get up. So she needs substantial help. So she needs substantial help for this thing. Now after getting the levodopa, what is happening? She was actually getting this treatment for 7-8 years. So the side effect of levodopa started. So this is the dyskinesia which she has developed after getting levodopa therapy. So this is a two-edged weapon. In that situation, you will have to go for reduction of doses in some situation, to go for the small doses of the levodopa in different spacing the time. Apomorphine is definitely one of the important substitutions for this reason. And last but not the least, the deep brain stimulation has come up in a very big way in the recent medicine. Now, acute Parkinsonian features, which may be due to sometimes neuroleptic induced and antiemetic exposure. Getting one single tablet of metoclopramide, you can have these types of problems. We should not forget there are certain important things like your organophosphorus pesticide exposure, sometimes sodium valproate, we do not know, but it can produce Parkinsonian feature, chemotherapy with CHOP, CNS infections, and other CNS disorders. These are to be kept in mind. Now, I have already mentioned about this Parkinsonism, primary only, idiopathic, but there was a time way back in 1929 when the bone economo, this is encephalitis. That's why nowadays we use the term Japanese B encephalitis. We say Japanese B encephalitis, but this is Japanese A encephalitis. So A term was mainly for the bone economo. This was mainly 3 forms, somnolent and ophthalmologic form, mainly presenting with oculogyric crisis, hyperkinetic form, and amyostatic akinetic form. The rigidity is extreme in that situation. Now, the Dale et al. Describes the encephalitis lethargica way back in 2005, 20 new cases. But these cases were actually not proved. Then they thought that probably bone economo does not exist right at this moment, but probably these manifestations were similar to that of bone economo, and probably these are due to the autoantibody against the basal ganglion structures. Encephalitic extrapyramidal syndromes are mainly 4 variant: neuroleptic malignant syndrome, you all know, lethal calatonia, Parkinsonian hyperpyrexia, and serotonin syndrome. Now, encephalitic syndrome, extrapyramidal syndrome, the role of thumb, we must have to exclude. This is a possibility when a patient present with neuroleptic malignant like features. The neuroleptic malignant syndrome is mainly due to dopamine receptor blocker. The patient presents with agitation, confusion, stupor. You all come across in general medicine ward. Temperature is very high. You will get the rigidity and autonomic disturbance. When you go for the laboratory test, there is a increased leukocytosis, CPK level is very high, myoglobinuria is there. Lethal catatonia, almost like that, certain precipitating factors are there. Other Parkinsonian hyperpyrexia syndrome take place in the background of sudden withdrawal of levodopa. That's why The second point, drug holiday is not given. You should not stop levodopa therapy when the patient is getting. Previously, there was a concept that when the patient is doing good, we can stop the levodopa for some time, for 2 to 3 days, like in the twice or thrice weekly. But this concept has gone. Otherwise, the patient can land up with a lot of problems. PD patients in non-medical ward, as I have already mentioned, serotonin syndrome, especially when you use the MAO inhibitors and selective serotonin receptors inhibitors drugs, they look like NMS, which can present with myoclonus rigidity. The same thing, TLC and CPK level should be taken into consideration, but that will be absolutely normal. And this is the most important thing in distinguishing between serotonin syndrome and that of a neuroleptic malignant syndrome. Just if you make a differentiation between the two, the onset in case of serotonin rapid, it is slower, symptoms agitation, diarrhea. Here you can get the hypersalivation, autonomic features are more, presenting signs, dilated pupil, myoclonus, and in this situation you get the extrapyramidal features like bradykinesia. Encephalopathic disease can be present in Wilson disease. It's not very uncommon. It sometimes may be fatal. Some patients have been reported when you have started the deep penicillamine therapy and they present with stupor, rigidity, siluria and seizures. This deep penicillamine actually chelates the copper and allows the copper to get deposited in the brain, and you can get all sorts of encephalopathic feature. So points to ponder is that, should we start the initial treatment with deep penicillin? Probably not. The answer is nowadays we try with zinc to start with. Nowadays this particular aluminum thiomolybdenate is not available in our country, trientry. But in other countries outside India, it's available. They start with these things, but we start with zinc first. Then after some times, when this gets stabilized, you start with encephalopathy. Then we think about some other important videos where you can see this boy actually is having, this is a status dystonicus, is a presentation of an Wilson disease, and after treatment especially with the baclofen and diazepam, you see this boy has become quiet. So this is important with the treatable conditions. Some stridor can present with a various emergency situation which can manifest itself as abductor paresis in Stridor syndrome. Also, you can get acute laryngeal dystonia sometimes which may present like an emergency situation. Neuroleptic induced acute laryngeal dystonia causing stridor is a lesson to remember. This patient was described by Dr. Chakraborty and et al. Way back in 2005. One patient was given haloperidol at night because the patient was restless, and after some time it was observed that the patient developed severe stridor. So they reported the case, and that was actually a drug-induced stridor. Pseudodystonic emergencies are also very important to remember. These are not classically dystonias, but infectious causes of torticollis is to be kept in mind, which is called the Gressel syndrome. Neoplasia torticollis sometimes is associated with some of the neoplastic disorders. Atlantoaxial dislocation, subluxation is very important to remember, and localized tetanus should be always kept in mind. History must be taken in every patient when there is a torticollis, any cut injury, etc., should be taken into. Torticollis, what should be the basic essentials? The basic essential in case of children who presents with acute non-traumatic torticollis should be assumed to have an inflammatory head and neck process, pathology especially. All patients with acute persistent torticollis must be assumed to harbor a non-traumatic atlantoaxial subluxation until proved otherwise. And in that situation, you should not move the neck instantaneously. Acute chorea and bellisms, these are the most important things in clinical practice. The commonest thing we encountered in our clinical practice is the vascular stroke. So if you see this boy, he had got a stroke in young, he has got chorea, this is a hemichorea. Actually, I will also show you the leg also is involved. This is a chorea on the left half of the body due to a basal ganglion involvement of the right side. So it's a stroke in young. Now, if you see this patient, this is another case. So this is an elderly patient who has also got a hemichorea on the left side due to the stroke. But I have shown you the one is a younger patient and an elderly. Actually, to start with, you can get the hemibellismus. When there is a stroke in the basal ganglion region, the subthalamic nucleus, you can get the hemibellismus. Maximum amount of, the flinging movements, sudden flinging movements. But later on, this hemibellismus gets converted into chorea. So if you get a patient starting with the hemibellismus, don't worry, because after some time, 72 hours, 48 hours, and in some cases maybe 7 days, they will ultimately turn into chorea. So this is a boy, sound ta dao. Hey bhai, sound ta dao. So you look at this boy, this video I have borrowed from one of the WhatsApp group. I think it's very important to show this video because you see this boy has got the orolingual dyskinesia, he has got encephalopathic feature and you see the sound. So he is just like a barking sound. So some people may mistake that this is functional disorder and maybe a tic disorder, complex disorder like Tourette syndrome like that. But you see, he is otherwise a healthy, absolutely healthy boy, but he is not responding to any command, any question, nothing of the sort. So he was put in one of the... So this is the thing you see.
नाम बताओ अपना, नाम बताओ, नाम क्या है, नाम बताओ.
So this is a boy who actually suffered from dog bite and he died after 48 hours of rabies. So this is due to the laryngeal dystonia, laryngeal spasm. He was getting this problem. So not to be missed. Very sad. So this girl was very recently admitted in our one of our and she was having these types of, you see, there are some amount of myoclonic movements are there. So also you look at the feet. So there is also, she was not responding to the command. She was almost in an encephalopathic state with these types of myoclonic disorders. We investigated her thoroughly and ultimately anti-TPO, anti-VPOT was very high. So she received the IV steroid. So this is a steroid responsive autoimmune thyroiditis. You need not think about the T3 and T4 in this situation. There is nothing to do with the T3 and T4. It's an absolutely different thing. And she got an indirect way to get response by giving steroids will prove the diagnosis. I will show you another case of our own ward. This gentleman was admitted. Probably I have shown this video in one of the last seminar, in one of the clinical meetings. And this gentleman was a COPD patient. He was admitted with a kidney disease. He has a great diabetes also in the background. So he has a stage 4 CKD. Along with this thing, you see there are some myoclonic jugs. So he had myoclonic jugs in the both in the upper limb as well as in the lower limb as well as in the, you see in the this is the hand, and also some amount of dyskinesia in and around the mouth and myoclonic jugs in the abdominal muscles. So considering all these things, if you find like that, it's a multifocal myoclonus. So the most important cause of the multifocal myoclonus is a metabolic encephalopathy. So we screened for the metabolic encephalopathy. We treated him in this line. We gave him the conservative treatment. And after giving the conservative treatment, you see, after giving the treatment for 3 to 4 days, how he is responding.
দেখি জিভ দেখান তো। হ্যাঁ, আপনি কেমন আছেন? ভালো আছি। এখন আর কষ্ট নাই তো? এই তো কষ্ট পাইলে কাশি একটা দাও। কিছু না পাবো। আর খাওয়া দাওয়া করেছেন? হ্যাঁ, খেয়েছেন।
So there is no myoclonic jerks or movements in the leg. Now, we have treated him for the COPD part and the kidney part.
একটু বসুন তো দেখি, ওরা সাহায্য করবে আপনাকে।
Original disease, metabolic part we have corrected.
হ্যাঁ, এইদিকে তাকান তো।
So Can the psychogenic movement disorder be as an emergency situation? Well, I was in North Bengal Medical College, so I got this patient and I show this video. It's a very favorite video of mine. I show these videos in most of the situations because you see these types of things is a horrible scenario for the patient, at the same time for the doctor, for the whole family. Where they will go if you get these types of patient? This patient was referred to me by one of the treating physician in my chamber, and I immediately made the video because I know that this video I will never get in my life. So this was the patient. He had, you see this video.
अभी क्या तकलीफ है दर्द है ना बहुत देर हो गया ठीक है अच्छा he has also some movements like
So you
this.
cannot fit it into any particular type of phenomenology of the movement disorder. So this is something which you cannot fit into. That's why you have to keep it in mind. Can the psychogenic movement disorder present like that?
ठीक है ठीक है स्टार्ट करो अच्छा
So sometimes if you get like that in a psychogenic movement disorder, you try to find out any triggering point. So you see what you are doing?
अच्छा एक काम कीजिए एक काम थोड़ा थोड़ा प्रसाद सर एक मिनट सुनिए प्रसाद सर हाँ सुनिए जो
So what I have tried to tell you within this short period of time, that means the different medical situations, medical conditions can come to us, starting from drugs to systemic disease. With these types of emergent situation, you will have to take a immediate decision because sometimes it may be life-threatening. So all the movement disorders usually has an indolent and non-emergent course. Sometimes it may be life-threatening. Although apparently perplexing for the clinician, a thorough understanding of the pathophysiology and spectrum is very, very helpful. A rapid diagnosis, a rational treatment are the essential part for managing this potentially devastating condition. Thank you very much for kindly.
It's a customary that whenever the chairman's address is there, we don't invite any questions. But still, if all the ones, one or two questions can be taken.